All right. Hi, everyone. Welcome to today's conversation, Bladder Cancer Breakthroughs 2025, New Treatments and Bladder-Sparing Advances. My name is Stephanie Truong. I am a cancer survivor and patient advocate and founder of The Patient's Story. And the mission really came from my own experience of trying to deal with a diagnosis and trying to navigate through all of the questions and not knowing. And so here at The Patient's Story, we're trying to humanize this information for you. Part of that is to give access to top cancer experts like today, Dr. Ashish Kamat from MD Anderson, so that you can learn more and empower yourself or your loved one in your care. We've also had more than 100 million views of our in-depth story video that's mostly featuring patients, sometimes caregivers, care partners, and of course, doctors. Our goal there is to also help promote self-advocacy and connection. So for today, a couple of housekeeping items. We do want to thank our sponsor, Johnson & Johnson, for its support of our educational independent program. This allows us to be able to produce more content like this and for free. The Patient Story retains full editorial control. And while we really hope that this is helpful, this is not a substitute for medical advice. Please still consult your own healthcare teams when making your decisions. And finally, we really want to hear from you. So there's going to be a survey that pops up after this discussion closes. It'll only take a couple of minutes. Please share your feedback on today's discussion and also what you want us to cover next. All right. So as you know, today we're talking about bladder cancer treatments in 2025 and beyond. So this follows big meetings, including this year's American Urological Association, or AUA, annual conference, where top researchers gather in the space to learn the very latest and have their discussions. Our focus today is on that. It's on what's new, what's promising, and of course, all through the lens of what patients and care partners need and want to know about to stay informed and empowered. So to help lead us through this really important conversation, I'm so pleased that Dr. Ashish Kamat has joined us. Dr. Kamat is an endowed professor of urologic oncology at MD Anderson Cancer Center in Texas. He leads many patient advocacy groups and efforts, including the World Bladder Cancer Coalition, just to name one. He's a global leader in bladder cancer research, clinical trials, and bladder-sparing strategies. 20 plus years in the field, just a few hundred publications, president of the International Bladder Cancer Group and International Bladder Cancer Network. Dr. Kamat, I already told you, I've got to pause after that. You've got so many things and accolades. But what I really want to say is first, thank you for joining us today. And that I've seen your name in so many of the patient-facing efforts and discussions. And so I'd really love to ask you, what drives you to go beyond the clinic, to try and get as much information and awareness out there to as many patients and care partners as possible, even those who are not in your direct care?
So Stephanie, first, thank you so much for having me on this forum and this group. And as you said, it's very, very important for us to reach out to patients, not just because of the fact that that is what we do, but if we don't do that and we don't get patients and their carers to be educated and involved and actually understand the disease process, then we can't get them the best chance of cure. It's not just the surgery, it's not just the medication, it's not just the radiation, but it's a true partnership. And in some ways, it's a selfish motive to get patients more educated because it helps me give them the best results, which in turn helps both of us.
I love that. And, I just, in the spirit of this conversation, I read one of your quotes, which was, nothing is more rewarding than hearing a patient say, we made the decision together. And I just loved reading that. So thank you so much for all that you do. So let's start this conversation by addressing some of the basics of bladder cancer for those who are newer to the diagnosis. So in this conversation, of course, this is not individualized and we're not able to address every single potential, situation on diagnosis. But in broad strokes, how do you categorize patients in determining what treatment options you might recommend? So would that be the muscle invasive, not high or low grade, staging? What goes into your ultimate recommendations when you're talking to patients?
Yeah, the first thing I always want a patient to understand is what disease state or what do they have, right? So from that perspective, I always try to have a patient understand that think of your bladder kind of like a balloon, and think of the muscle layer being the rubber of the balloon. Just like a balloon, the bladder, when it's empty, it's all, collapsed and it's empty and it's crumpled. When it fills up, the urine gets larger and thinner. And now with that analogy, think of the muscle layer being the rubber of the balloon. There are two layers on the inside, then there's the muscle on the outside. When these tumors start, they start on the inner surface of the bladder, but they set their roots down towards the muscle of the bladder. And that muscle of the bladder getting involved, or the rubber of the balloon, so to speak, is the key determining step as to whether it's safe to save the bladder or not. And that's the first thing that I like patients to understand. Do you have muscle invasive disease where our focus now shifts towards, can we save the bladder? And if not, do we need to do radical surgery? Do we need chemotherapy? Do we need to do trimodal therapy with radiation? Or is the tumor not even in the muscle yet? And in that case, we'll aim to save the bladder, but then what do we need to do? And once I go through that general broad categorization, then I help the patient understand, is it a low-grade disease or a high-grade disease? Because when the tumor is non-invasive, you can have low-grade disease, which again is still cancer, but for most practical purposes, you can almost treat them like warts. They're nuisance factors, they require intervention, but they're not going to threaten our patients' lives. On the other hand, you have high-grade tumors, which may be small, smaller than just a point of a pencil, but they can kill the patient. So it's important for the patient to understand that just because it's not muscle invasive, if it's high-grade, it can still be a threat to his or her life. That's the majority of patients that we see. Now, of course, there's a small percentage of patients that present with de novo metastatic disease, where the cancer is already spread outside the bladder to other parts of the body. And if that happens, then I try to help the patient focus our discussion on, okay, if the tumor's left the bladder, let's focus on how we have to treat the rest of the body first, and then bring our attention to the bladder to see if at some point we still need to address what happened in the bladder to begin with.
Thank you for laying all that out. Can you give us some color into how many patients typically land in these categories in terms of muscle invasive and not high grade, low grade?
Sure. The most common presentation for a patient is non-muscle invasive disease. And it's usually about 70 to 75% of patients will present with non-invasive disease. Roughly 20 to 25% patients will present with muscle invasive disease, where it's already in the muscle of the bladder. And fortunately, only about 5% of patients present with metastatic disease, because purely that's where cure is hard. Unfortunately, it is gender differentiated, right? So women tend to have a higher risk or percentage of presenting with more advanced stages of disease. And partly that's because when the most common presenting symptom of bladder cancer is blood in the urine, you can imagine many women, especially young women, get told, hey, it's not anything to worry about. It's just that time of the month. It's probably just contaminated sample. So it's really important for primary care physicians and females in general to know that, hey, if you see blood in the urine, don't ignore it. Let someone know.
I really appreciate that. We've certainly done lots of these stories, and that's something we hear commonly, right? It's especially as a woman, easy to sort of either dismiss or attribute to something else. So always, if you don't feel well or something's not right, it's something that is concerning for you. You're saying advocate for yourself, find someone who's going to address that. Is that right?
Absolutely. Absolutely. I mean, the best advocate a patient can have is themselves and their family, and of course, us as partners, but they have to find the right advocate. And before they find someone to advocate for them, I really want patients to empower themselves to say, hey, I'm not willing to take this response that you're giving me saying it's nothing to worry about. I hope it's nothing to worry about, but tell me why it's nothing to worry about.
Absolutely. Absolutely. I read also a way that you sort of described the non-muscle invasive bladder cancer situation, which, as you just said, most people are diagnosed with, it behaves more like a chronic condition that requires the ongoing care. But it does require that because of, I think, high recurrent rates. Can you talk more about how that informs your approach with those patients?
Yeah, Stephanie, that's where it's really important to get the patient and their family involved early, kind of set expectations a little bit. But also, I like to ask patients, hey, tell me what's important to you, right? Because non-muscle invasive bladder cancer is a chronic condition, and we want to make it a chronic condition. We don't want to make it such that a patient is diagnosed and then they die from their cancer, right? So if we do the right thing and we treat the patients correctly, we are saving their bladder, but then the bladder is at a chance of the tumor recurring. In some ways, I kind of, allude to this when patients, it makes it easy to understand. Think of your backyard. You got a couple of weeds, you see them, you want to treat them, but then you still have the backyard in place, right? And unless you remove the entire sod, you're going to have weeds pop up. Some patients will say, you know what? I can't keep coming to the doctor's office every 3 to 6 months. I just live too far away. I had to have my grandson or granddaughter take time off to bring me there. Can you just give me a one and done treatment? And in that situation, sometimes even for non-invasive disease, we will do a radical cystectomy, which is remove the entire bladder, because yes, that is a drastic step. But for a particular patient, unfortunately, a small number of patients, that is something that they really want because it's a one and done thing. I don't encourage that, but since you asked, it's really important for me to know from a patient what is their desire from their treatment paradigm. And if a patient tells me I want just a one-shot treatment, then of course we have to do a drastic step. But for most patients, it involves regular checkups, regular treatments, evaluation of the bladder, cystoscopy, cytology, imaging, et cetera, et cetera.
So for a lot of people, their decision making is largely based on efficacy, like how well will this treat the disease, but also the impact quality of life, which is something we talk about across all kinds of cancers. Is there anything else upfront that you really want to make sure that the patients and their families understand? Are there other factors, for instance, that might, inform of a different way of treating them? We hear a lot about biomarkers in the space of a lot of solid tumors in particular. If you could give some color on that, that'd be helpful.
Yeah, so, biomarkers is a field that we and most of us in this oncology space, of course, are very, very interested in. And biomarkers are helping us understand the biology and differentiation of bladder cancer treatments and paradigms and development, et cetera. But in some ways, we're fortunate in the sense that the best treatment for non-muscle invasive bladder cancer is biomarker agnostic. It's an immune therapy, it's intravesical BCG, and it works so well that we haven't needed to use biomarkers to change or inform the treatment paradigm. Now, I see some patients sometimes walk in and they have sheets of papers where they're paid out of pocket to get all this testing done. It's not helpful. It really is not helpful other than a research tool or an educational tool. If a patient wants to understand, hey, is my cancer being driven by FGFR3? Is it PD-1? Is it something else? That's great for education, but it doesn't help us in today's day and age in the upfront treatment. Now, if the tumor doesn't respond to the first-line therapy, then yes, absolutely. We will want to do a biomarker analysis because there are FGFR-directed therapies, there are specific RB-directed therapies, but for that, we want to look at the tumor that develops after the treatment has not worked, right? So looking at the first tumor itself, again, it's not cost effective for the patient. From a research perspective, we do biomarker analyses all the time. This is more for patients. Don't spend your own money doing all of this. It's not going to help you or us upfront.
Thank you. That's, again, really important because I think we hear things, in the world of like science and major news publications, and it's hard to understand like what actually applies to our specific situation in cancer. Before we dive into more of the latest and promising therapies and options, again, broad strokes, what typically is the treatment decision-making path or the options given based on these larger categories of patients? So if you're talking about the non-muscle invasive bladder cancer and then high grade versus low grade, here's how we usually do this. High grade, here's what we normally recommend. Could you provide a more basic picture of what that landscape is?
Sure, absolutely. So let's assume, there's a patient sitting in front of me and he or she has low-grade non-muscle invasive bladder cancer. So the first thing in that situation to explain to the patient is that that's great news. If you're going to have any kind of bladder cancer, this is the one to have because yes, it is cancer, but it's extremely treatable. And even though at some point in your life it might recur, the recurrence is not a problem, right? So for the treatment of low-grade non-muscle invasive bladder cancer, the treatment is removing the tumor. And that's usually done with a transurethral resection. We look in the bladder with a scope. currently use electricity. You can also use laser in some places. There's no real benefit to one over the other. Remove the tumor and then give a single shot of chemotherapy in the bladder. That's what the majority of patients need. That's what the majority of patients respond to. Now, some patients have a recurrence of tumor, and so long as the tumor stays low grade, that patient then transitions into what's known as an intermediate risk category. So it's not high risk, it's intermediate risk. And the only reason we call it intermediate risk is because we just want people, physicians especially, to understand that, hey, it's gone from low risk to intermediate risk, so we might need something more. What is that something more? That something more is intravesical therapy. And intravesical therapy, either in the form of chemotherapy maintenance, so once a week for 6 weeks, and then monthly chemotherapy maintenance, or intravesical BCG. Now, there's a shortage of BCG across the globe. So in today's day and age, we don't tend to recommend BCG for patients with low-grade disease, not because it doesn't work well, but because there's not enough BCG, and it really is something we need to reserve for our high-risk patients. So for the low-grade intermediate risk patient category, the treatment currently still is intravesical chemotherapy. Now, there are paradigms where, and for patients who are maybe sick enough that they can't go to the operating room, or say they've had a recent MI or heart attack and they're on blood thinners or Plavix or aspirin, and we want to avoid a procedure, we can ablate these tumors with chemotherapy up front. And there's, of course, newly approved agents. Just last week, the FDA approved a mito gel, which is mitomycin in a gel format for that group of patients where you can ablate the tumor. But that's in some ways, a selected group of patients, those that are trying to avoid resection of the tumor or we are trying to buy some time before we can take them to the operating room. Now, moving from that low risk patient or low grade patient with the low intermediate risk category, the next category is the high risk patient. Any patient with high grade tumors is considered high risk. And that includes carcinoma in situ, whether it's CIS or T1 disease, et cetera, et cetera. There's a lot of factors that play in as to treatment recommendations. So patients that have high risk tumors can be further categorized or counseled into their actual risk. If they have certain parameters that make them extremely high risk, and I'm talking now risk of progression and metastatic disease, I might recommend to a patient saying, hey, your tumor is non-muscle invasive, but it's getting there. It's getting to become muscle invasive. So you might still want to consider radical treatment up front. Fortunately, that's a small percentage of patients. And for the majority of patients, we can still recommend treatments that allow us to spare their bladder. The gold standard for many years, for the last 40 plus years, and it's not been dethroned yet, is immunotherapy. It's intravesical immunotherapy with BCG. BCG is developed from the tuberculosis vaccine. It's been used for other cancers in the past, melanoma, leukemia, etc. But it was toxic because you had to give it in the blood. In the bladder, we can put it in the bladder. And even though the early data suggested that it was fairly toxic to patients, that's because people just didn't understand how to use it. If it's used appropriately today with appropriate pre-medication or interval spacing, etc., most patients, 90% of patients, can actually finish the whole 3-year prescribed course. And if you use adequate BCG, the recurrence rates are in the teens and the progression rates are in single digits. So 90% efficacy when it comes to preventing progression of disease of high-grade bladder cancer, which allows 90% of patients to spare their bladder. But again, nothing's 100%. And if it doesn't work or patients can't tolerate it, we have to use other treatments. And that's where you've seen this explosion of drugs coming up recently. There's gene therapy with nadofaragene, there's CG Oncology's drug currently, there's intravesical pretzel devices, there's Antiva, which is, the BioShield that Dr. Shimshong's been talking about all over the world recently. All of those come in after BCG has not worked for a particular patient.
Thank you. I know it's a lot to talk through. We will be talking about all this about the course of the explosion so that people understand, what they can consider and weigh might be really good for them personally. Let's see here. So just to wrap this, going into what's new, biomarkers really hasn't been a thing yet in bladder cancer. That's largely a good thing in that most people don't require that. The the standard of care has really worked well. But as you had mentioned, there are meetings and gatherings where people are trying to figure out more about how they may play a role in bladder cancer. Is that right?
Absolutely, Stephanie. And we were talking now about non-invasive disease. So now if we move into the muscle-invasive space, there the biomarkers are showing more promise, and they're slightly more utility. They're still not used in the clinic. They still don't inform how we actually counsel a patient, but they help us inform the patient about their prognosis, right? So if we now move to the muscle-invasive space, patients that have muscle-invasive disease, the discussion with the patient now becomes, well, how can we get you the best chance of long-term cure? And that usually involves some form of bladder removal. There is trimodal therapy, which in selected patients can offer the option of sparing the bladder and providing long-term control, but that's the minority of patients. The majority of patients do require radical cystectomy, unfortunately, to remove the bladder. And then to give them the best chance of long-term cure, there is neoadjuvant therapy, and now with new paradigms, sandwich therapy that comes into play. So neoadjuvant therapy essentially means getting treatment before the surgery, and traditionally it's involved using cisplatin-based chemotherapy, which can be fairly toxic, and roughly 40% of patients don't even have the ability to get cisplatin because of cardiac disease or renal dysfunction or age or neuropathy or something else. So other drugs have been studied and are being studied to see how this can help us give patients who are not cisplatin candidates some treatment. In more recent times, the cisplatin combination has been combined with immunotherapy, immune checkpoint inhibitors, and the Niagara protocol, which is the most recent development in this space, essentially suggests that combining combination chemotherapy with a checkpoint inhibitor prior to surgery and then continuing the checkpoint inhibitor after surgery can offer the patients the best long-term chance of cure in the muscle invasive space. And this is where the biomarkers have come in handy, right? So there are biomarkers that people have developed trying to help us understand which patients may respond so well to the systemic therapy that we don't have to take the bladder out. Again, this is being studied. It's not something that I can say a patient should go to their physician and say, hey, I have this biomarker. I don't want my bladder out. No, it's not ready for prime time, but we're looking at those, right? There are DNA repair genes. There are other agents and other markers we're looking at. And then the biggest sort of buzz is around circulating tumor DNA, because there's data and evidence that's come out that suggests that in patients that have detectable levels of circulating tumor DNA, it puts them in a category for prognosis that is not as good. And if they don't have circulating tumor DNA, then it gives them a better prognosis. And again, this is a research field, but it's being studied in the sense that if a patient has elevated ctDNA, do we need to escalate their treatment? If they don't have circulating tumor DNA, can we de-escalate that treatment? In other words, less toxicity, but just the same efficacy. And a trade-off, of course, is we need to offer the patients this shared decision-making, because like I said, currently it's not standard of care. It still is a research question.
Thank you so much. Before we dive even deeper into the details of what's new, what's latest, typically, and I know it depends on whether someone's getting care at an MD Anderson versus maybe a community provider or a different practice, a different clinic. What is the makeup of the bladder cancer care team? And does that impact what you recommend to people?
Yeah, no, one of the things I've been a champion of for all the time I've been in doing this, and I think in many parts of the world when I'll travel, when I'll help set up their cancer programs elsewhere, is to emphasize that bladder cancer is a multidisciplinary cancer. In order to give our patients the best chance of cure, it has to be such that everything is considered, right? So it's not, yes, I am a urologic oncologist on the surgical side, but bladder cancer is not a surgical disease or a medical disease or a radiation disease. We have to look at the patient holistically. And that's why whenever we're guiding patients as to where to get their care, I can't have everybody fly into Houston to be treated here at MD Anderson, but I tell them, hey, wherever you seek your care, make sure that the care team over there is not just one person, that it involves not just the surgeon, but also the medical oncologist, the radiation oncologist, the nursing team, the support staff. Everything is really, really crucial, because example. Bladder cancer is not one of those diseases that you get second chances with, and you want to get the best treatment right up front. And the whole team effort is very, very important.
Actually, follow up there, then, Dr. Kamat. You see, I'm sure, a lot of people who have traveled to see you, given your expertise. Are there common situations you're hearing from them? Hey, I saw such and such person. They're not a bladder cancer specialist, and they wanted to immediately go to this step, or things that you're seeing at different levels that might make it harder for patients to actually understand what's good for them.
Yeah, and that's why things like the patient story are very important, right? Because I see that very often. Patients will come in and say, "This is what I was told. I have no choice. I have to do this." And first off, every patient has a choice. So when I hear that, that itself makes me not very happy, because patients always have a choice. Our role is to guide them to make what I think is the best choice for them, but it's very patient specific. Like I said earlier, for what may be right for one patient, surgery may not be right for someone else, and it might be purely based on their beliefs or their support structure and things of that nature. But the other thing that often gets us is that if a patient goes to see someone that doesn't do bladder cancer all the time, it's not their fault, right? It's not that physician's fault. The physician's trying to do the best they can. But if they're treating 10 other cancers or 10 other problems, I can't expect them to be at the forefront of the latest in that arena. So they're now offering the patient what is the best treatment in their honest opinion, which might not be the latest cutting edge. So I always recommend to patients, go get that second opinion, right? Even if they come to see me, and they want a second opinion from somewhere else, go get it from somewhere else, because it's good for patients to hear from at least two separate people if that treatment truly is the best treatment for them, and then make the decision. Now, of course, when patients have to get treated, if it's chemotherapy, for example, I often tell them, hey, you don't have to be stuck in Houston for the entire duration. Go back home. Your physicians are extremely qualified. Everybody can give the chemotherapy, so long as they're willing to follow our protocol or our recommendations. Get the chemo to where, it's easier for the patient. When it comes to surgery, it's slightly different, because the surgery for bladder cancer is extremely specialized. It's not something that most people can do unless they're highly trained. And it's not something that I recommend patients just go to someone that does, it once in a while. It's very important to go to someone that does it all the time, has a team to support them, not just the surgeon, but, the nursing staff, the ICU staff, the anesthesia, the stoma nurses, et cetera, et cetera. And ironically, in many ways, people forget that that's just as important when it comes to radiation therapy. Because even in radiation therapy, it's not the machine that's necessarily important, right? There might be multiple places in the country that have a good machine, but it's the person, the radiation technologist, the radiation oncologist that's planning the treatment paradigm that can make a difference between radiation that helps save the patient's bladder versus radiation that causes so many side effects that the patient then loses their bladder and their rectum, right? So that is very, very important.
How, and we'll, of course, provide resources on the side and follow up emails with our audience, but where can people go to figure that out? The MD Anderson, world class, people know about it. But in terms of figuring out, is this the right surgeon? Is this the right institution or clinic that has, people who can do the radiation therapy that we need to, with the precision we need? How would people go about finding that?
So there are resources online. There's a lot of junk online, but there are some good resources, right? Your institution, of course, the Bladder Cancer Advocacy Network, Beacon, is a very good, reliable place where patients can go, because it's all for patients by patients. I recommend to patients that they make that their first stop. On a global scale, the World Bladder Cancer Patient Coalition has good resources. But of course, I always tell patients, ask your family doctor, ask your local physicians, hey, who do you trust here, right? Who would a patient's family doctor send their own family to? Because that's important as well. Not everybody that does bladder cancer makes it onto these resource sites, right? Just because I haven't trained someone or I haven't heard of them, but they're in Boise, Idaho, doesn't mean they're not doing excellent work. So the local community of physicians often knows who is good, and conversely, often they know who may have published 5,000 papers, but is horrible, right? It's not just academia. It is really taking care of patients that's important.
I really appreciate a lot of what you said there. I also want to go back to what you said earlier, which is that a lot of the practicing physicians, it's not that they aren't smart, it's that they are more generalists. And there's no way with all the advancements happening at the pace they're happening at that they could keep up with all of the things that are happening in the research. So thank you for that color. So let's dive into more of really, you talked about already some of the explosion of options that have come up recently. You talked about gene therapy, pretzel devices. You said BioShield coming in after BCG hasn't worked. Can we go through some of the ones that you're most excited by? And again, what in the spirit of what patient group would be most interested in each of these options?
Yeah, I think the biggest explosion of data has been in two separate spaces, right? And the first one I'll talk about is the patient that has high-risk bladder cancer, has tried BCG, and BCG has not worked for him or her. And the patient's now faced with a conundrum as to what do I do next? The standard treatment for many, many years was remove the bladder. And the reason for that was there were no real drugs approved. There was nothing really available. And unfortunately, when drugs were approved, they had 4 to 5% success rate at 2 years, right? No patient wants to hear, hey, I'm going to try something that has a 4 to 5% success rate. So because of that, different organizations came together and the FDA actually partnered with a lot of us and developed this paradigm of BCG unresponsive disease. And as many of your patients that are listening in might know, there was an explosion of drugs studied in that space. And that's the space that currently has the most activity. So if a patient has tried BCG and still has recurrent high-grade disease in the bladder, what are the options? That's where the drugs have been approved, and that's where drugs are being studied, and that's where some of the agents that I talked about come into play. The first drug that was approved in that space really is pembrolizumab, which is systemic IO therapy. And the results with those were very exciting at that time, but obviously there was some toxicity. So not many patients today will get single agent pembrolizumab for BCG unresponsive disease, but there are studies now using pembrolizumab with other agents that I think will offer patients the opportunity to get that systemic therapy backbone plus something else. The next agent that was approved in that space was intravesical gene therapy, nadofaragene. Now, this is a gene therapy that allows the patient's bladder to, in some ways, become a bioreactor because it transfects the bladder cells with adenovirus that then helps production of local interferon alpha 2b. And that has the advantage in the sense that it's given in the bladder once every 3 months. So the patient doesn't have to come to the clinic every week. They don't have to come to the clinic every other week either. It's once every 3 months. The efficacy number is there roughly at about 12 months is 25% of patients will have a positive result and be in disease remission. And that's great, right? Because we can tell the patients, hey, it's approved for BCG unresponsive CIS. Let's try it. If it doesn't work, we'll know and we can switch to something else. But if it works, it's great because it's once every 3 months and you might have at least a 25% chance of saving your bladder just with this treatment. The third drug that was approved in this arena is the IL-15 agent, the IL-15 superagonist, which I've seen, again, a lot of buzz about. It's been called the BioShield by some people because there is some evidence that IL-15 might actually have efficacy across different cancers. But of course, that's a different topic. But here for bladder cancer, it's given in combination with BCG, and it helps boost the patient's own bladder's immune response to BCG itself. That really has excellent results in the sense that more than 50% of patients have a response at a year. The downside of that is that it has to be given in combination with BCG. And again, kudos to the company because they have gone out and they've actually gotten the FDA to agree to allow non-US BCG to be brought in the country and used in combination with this agent, especially in places where there's no BCG. So those are the approved drugs. The same space now has multiple different drugs that are being studied. One is, cretostimogene, which is another gene therapy that focuses on the RB pathway. It's an oncolytic virus. Excellent results. Not approved yet, but many of us expect that it will be approved. Then there's the intravesical pretzel device, which is where chemotherapy, gemcitabine, is put in a little silicone sort of a device that in many ways looks like a tiny pretzel. The company doesn't like us calling it the pretzel, but it's what helps patients understand. It's put in the bladder and it releases the drug at a slow rate. So it's great for patients because you put the device in once, and then the patient just has to come in after 3 weeks or 12 weeks, depending on what stage they're at, and have the device removed. But it's constantly releasing gemcitabine. Again, it's not approved, but the data is looking promising. Everything that was presented at AUA and ASCO and elsewhere really looks like this is something that's really going to be beneficial to our patients. And then there are other agents. There's non-viral gene therapy, such as the N-gene, which allows patients to get gene therapy without using a virus. Some patients are afraid of the whole viral paradigm when it comes to gene therapy. Some hospitals in smaller communities can't get certification to use gene therapy that's viral based. So if this is approved, again, we don't know yet, but if it's approved, it'll allow patients in smaller centers, smaller communities to get this drug. Beyond this, gosh, we don't have that much time. I could go on for 2 hours, but there's so many more drugs being looked at, laser therapy, et cetera, in this space, that it really is a great time not to be a patient with bladder cancer necessarily, but if you're going to have bladder cancer, this is a great time because there are potentially many options that are going to be available.
No, I know that we could spend much more time, and we don't have it, unfortunately, to go through every single amazing potential development and promising research happening. But let's dive into some of the ones that you already talked about, and then I have a couple of follow-up questions too, about how you would offer what therapy at what time, because I think in any space, and not just in bladder cancer, when we have these conversations in other cancer spaces, there's a lot of question about, do you use a lot up front first, try to hit hard in certain disease, in certain diagnoses or not. So first, you talked about the gene therapy, the first one you talked about. Can you actually say the name of the therapy and share a little bit more about how close we might be? I know you don't have a crystal ball, but how close are we perhaps for patients to actually see this, in clinic? You can't tell if the FDA is actually going to approve something, but if it's promising and it does get approved, is this like in 6 months, it could be something off of clinical trial and approved and available?
So just to clarify, the gene therapy nadofaragene is already approved, right? So that's the interferon alpha therapy that's already approved. Patients are using it, and that's where we can actually offer it to patients. The other gene therapy is cretostimogene, and that's the gene therapy with CG Oncology. That's not approved yet. We think that they will go in front of the FDA within 12 months and hopefully will be approved and used for patients at that time. So the results look great, but it's not approved. So we can't really recommend it at this point.
I mean, we will talk about clinical trials also before the conversation's over, and how you explain it to your patients. The term itself is not very friendly, I think, clinical trial, pretty daunting for people. So we'll humanize it. But I realize that there's already gene therapy approved, like you mentioned, but the one that you just said is still in research. How does that offer, when you're thinking about gene therapy then, in this case for patients, let's say that someone is able to go onto this clinical trial if it was recruiting, or let's say that it was already approved. Why is this one better for certain patients than the one that's already approved?
Yeah, so there's not any one particular drug that's better for a patient. And in fact, when it comes to sequencing the right drug with the right patient, this is a very complex problem. The International Bladder Cancer Group that I lead, we actually had convened a think tank, just spent months thinking about this, and actually had 100 faculty from all over the world come here to Houston, sit in one room and hash this out, to try to figure out how to best sequence these drugs for the patients. The short answer is that there's not one clear drug that's better for every patient. It's a personalized decision. So there are some patients that might benefit from treatment that's given once every 3 months, in which case it's obviously the nadofaragene. If the CG Oncology's cretostimogene is approved and it's available, that's every week for 6 weeks, and then there's a maintenance that goes with it, right? But the efficacy numbers there are higher than with the published data with nadofaragene. So a patient might say, hey, I want to try this. I don't mind coming ever so often. I don't mind the side effects of it. I really would like this drug. So that becomes a discussion with the patient. And it's not just these two gene therapies, right? There are other treatment options that are available as well, which is for example, the IL-15 NAI. Patients might like the fact that it's given in combination with BCG and say, hey, BCG worked for me. It just stopped working after some time. I would rather get that treatment. And then, of course, there are patients that may say, I don't want any of this intravesical therapy. I want to get that device that you can put on my bladder because I like the fact that you can put it in. I don't have to come back for X number of weeks, and it's constantly releasing the chemotherapy in my bladder, and I'm having good results with it. So I don't mean to dodge your question, but the real answer is there's not one treatment that's the best treatment for everybody.
No, I appreciate that. And I actually probably should have said it differently. That's exactly what I think the question is we're getting to a space of personalized and figuring out, when we say personalized, not just in terms of the disease, but what a patient prioritizes for his or her life. And I, again, appreciate that that's how you approach your own patients and how you bring this to light and at the forefront of these discussions, because it is different, right? People are optimizing for different things in their lives. So again, really appreciate that. Then let's talk about I know you said they don't like the pretzel name, but can you talk about what is the name? If it's in clinical trial, we'll also be putting up the clinical trial names for people, just in case they are interested in asking their doctors about these. So before we move on, do you have the clinical trial name for the gene therapy, the one that's the CG oncology
Yes.
clinical trial?
Yeah, exactly. That's the Bond study. And the pretzel is TAR 200 and TAR 210, and that's J&J's Moonrise and Sunrise paradigms. And there's 5 Sunrise studies. And, again, full disclosure, I think I told you at the very beginning, I'm part of advising pretty much every company in the bladder cancer space. So I help advise all these companies as well, just to disclose that out there. But that is the Sunrise paradigm, Sunrise 1, 2, 3, 4, 5, and then the Moonrise, which is using the 210, which is again the actual name. We don't know what the company is going to call this when it actually gets approved in the clinic. Yeah, there's lots of names being thrown around, and of course I can't reveal that anyways. But we don't know what the final name for any of this is actually going to be, and that's really all this in the non-invasive space. I'm looking at the clock, and we don't have that much time, so I also want to enlighten the patients on the muscle-invasive disease and the metastatic disease, right? So in the metastatic space, this is not brand new, but EV Pembro, right? Using enfortumab vedotin with pembrolizumab clearly has changed the treatment paradigm. It used to be about 8-10 months ago, we would tell patients with metastatic disease that, hey, the median survival is 14 months, which means half the men and women will not live 14 months. Then once EV Pembro was studied, presented by Tom Powell at ASCO, you got a standing ovation, of course, as many of you know, because it really changed the paradigm for patients, where now we can tell patients, hey, you have metastatic disease, and yes, it's still not great, but the median survival has jumped from 14 months to 30 months, right? So half the men and women will live 30 months, and that's great. And that's EV Pembro. And in the metastatic space, a lot of second line, third line therapies are being studied. That's where you have clearly FGFR directed therapies, you have cisplatin-based combination therapies, you have other antibody drug conjugates, and that's being developed for patients with biomarkers, et cetera, et cetera. So still a lot of work needs to be done. It's not as though EV Pembro is a full stop, right? We still need to get patients to live longer than a median survival of 30 months. Now, in the muscle invasive space, where patients have muscle invasive bladder cancer, but they're trying to save their bladder, a lot of research is being done in can we avoid a radical cystectomy? And the treatment paradigm there is to give that neoadjuvant therapy, whether it's cisplatinum based with GemCis plus X, and then get the patient to where there is no tumor left in the bladder. Traditionally, what's happened is if you don't take the patient's bladder out, these tumors recur in the bladder. And when they recur with a vengeance, and they actually get worse, and then you've missed that window of opportunity. Now, with the improved tools that we have, where we can use really good cystoscopy, bladder MRI, using circulating tumor DNA, there is data emerging, and it's still being studied in a clinical paradigm, though, but there is data emerging that we might be able to select a subgroup of patients where it might be safe for them to get systemic therapy and not necessarily have their bladder removed. But that, again, just to caution people that are listening, is a clinical trial paradigm. One of the trials that is being done in that space is the modern study. And, Dr. Matt Galsky is the PI for that. It's great because that gets patients to see, hey, I've achieved this particular endpoint. Now, on a clinical trial, can I continue on and not have my bladder removed? That's the clinical trial part of it. But in the actual clinic, we are now looking to improve results for patients that are wanting to have their bladder taken out. And that's where the Niagara protocol, which is using gemcitabine and cisplatin, which to date used to be used alone as a combination, but now you can combine this with Durva, which is an IO, give this to patients up front, they undergo radical cystectomy, and you continue the Durva after the surgery. This really has improved their survival. And it's the first time that the overall survival has shown an improvement in patients that are undergoing radical cystectomy. Because for many years, we've used neoadjuvant therapy. The benefit to patients is about 5%. Nothing has really improved upon that. People have tried to improve upon that. We've used different types of chemotherapy regimens, dosed NSAMVAC, whether it's spacing out chemotherapy, etc. But this is the first time that this combination therapy is actually shown in a randomized phase 3 study to actually improve overall survival for these patients. So clearly changes the treatment paradigm. And again, in the interest of time, I'm not going to go into too much detail, but there's so much in between that is being developed and has been developed that I really encourage patients that are faced with, the paradigm or the conundrum of having muscle invasive disease, ask the physician, hey, I know that this is standard of care for me, but if it doesn't work, what else do you have available? Because there's a lot of stuff that's available.
Thank you. Yeah, glad you let it all in a very concise way, given the time crunch. I do want to go back to some of these because when people are hearing about it, it's great that they have the information, but there are lots of questions about, there's the efficacy, of course, and then there's like the impact to quality of life. You've talked a lot about bladder sparing, which I think is a huge part of what we've heard in terms of questions from patients as well, since there is such a high degree of impact to them. So first, going back to the non-muscle invasive, with the gene therapy, you have, different considerations. One of them is once every 3 months. One of them is onboarding, or the on-ramp is once every week for 6 weeks. What else side effect profiles? Are you seeing something much better in the one that's in clinical trial now, for instance, for the quality of life for people?
No. And again, it's not as the side effect profile is majorly different or better or worse in some ways. Patients that will get side effects, you'll see that up front. Most patients will have some localized side effects in the bladder, but it's very manageable, very tolerable, especially since we can give patients antispasmodics, et cetera. But there doesn't appear to be any major difference between the side effect profile of one over the other.
Got it. Thank you. And then a follow-up on the pretzel device. I think with people that's, it's novel. People haven't really heard of, have lots of questions about how does this work? Do people go into the doctor's, the hospital, and then it's put in for them, and then they have it, and it automatically releases the treatment, the therapy, and then how often are you going back in? And then is that indefinite, or is there a particular amount of time that you're supposed to have that pretzel device in?
Yeah, so the way the clinical trials are designed is essentially the TAR-200 device, which we colloquially call the pretzel. It's put in the bladder with a device which is kind of like a catheter, right? So it's not a major surgical procedure. It's not like you have to have anesthesia or anything. It's local anesthesia. You put that in the bladder, it's taken out, and the patient just keeps that in place. Most patients initially will feel like there's a little bit of a foreign body in there, but patients are in some ways used to it because they've had prior treatment, and it's something that you can easily treat with antispasmodics. After a while, patients sometimes forget that they have this in there. Now, in the early stages of the treatment, the device has to be changed more often, which is in 3 weeks. So they come in once in 3 weeks and they get that device changed. In the maintenance phase, it has to be changed roughly once every 3 months. So they can leave it in there for that long. It doesn't really bother most people. Like I said, sometimes we have to remind patients that they have a stent in place, right? We don't want them to forget that they have it and never come back. Hopefully that's a good problem to have, but we don't want them forgetting they have it in there. And so it's once every 3 months. And like I said earlier, that's where the personalized the discussion with the patient comes in, right? Some patients are more than happy to come into the office ever so often, and some are like, no, if it's once every 3 months, I much prefer that treatment paradigm. So I think we'll have different things to offer to patients. But if you look at the efficacy numbers, it really looks like one of these newer agents that are not approved might actually end up with the best efficacy numbers. We just don't know that for sure yet.
Great. We're still waiting for that actual data. And then lastly, as we're wrapping this second to last question, the EV Pembro, which you're talking about the ASCO and the standing ovation, can you, in other words, put into perspective what this means for patients who typically, again, were looking at pretty rough numbers before?
Yeah, no, so again, traditional first-line chemotherapy for patients was cisplatin-based chemotherapy. Many patients could not get cisplatin because of the various comorbidities that our older patients tend to have, especially those with bladder cancer, with prior, smoking history, cardiac disease, etc. And they had to get non-cisplatin-based therapy. So there was a lot of push to study IO therapies, pembrolizumab, atezo, etc. And then, of course, the antibody drug conjugate, which is enfortumab vedotin, which is targeted Nectin-4. Long and short, this combination was studied in the patient population and compared head-to-head with standard chemotherapy and clearly improved survival over standard chemotherapy. So now it's become the de facto first-line therapy for patients with metastatic disease. But a caveat there, it's not available everywhere in the world. It's expensive. It's not easily available. So there are many places in the world where patients still don't have access to EV Pembro, or if they have access, it really is something that can break the bank. And again, that's a practical problem that we all face, right? Resource allocation, who gets the treatment, who can get the treatment, who can afford to get the treatment. But so long as a patient has access to it and it's available and affordable, EV Pembro today has become the de facto standard of care.
Thank you. Last question. We've talked about clinical trials. Without going into the details of these specific trials, it's something that a lot of people are not familiar with. What tends to be the way that you have found most effective in describing what a clinical trial is and why certain patients, you bring this as an option to, why they might want to consider it? How do you humanize the concept of a clinical trial to them?
Yeah, no, that's a very important question, right? And I think it's important for patients to understand that a clinical trial does not mean that they are being treated like guinea pigs. That's the furthest, from the truth. There are some patients who unfortunately don't have any option because they haven't responded to anything. And at that point, of course, it's a matter of life or death. It's either clinical trial or nothing. But for the most patients, that's not the situation, right? So for patients in front of me and they have different options available, but there's a clinical trial in the space, what I tell them oftentimes is, hey, this particular agent that's being studied in the clinical trial is something that we believe in. We know from data that's in the preclinical space, the early data, that it actually has good mechanistic reason to maybe actually be better than standard of care at some point. We don't know that yet. We have to study it. The advantage of taking part in a clinical trial for every patient is that they are at the forefront of the research, but also they get better care, right? Because if a patient's in a clinical trial, by definition, they are being followed very, very closely. There's usually a nurse that's assigned to them. Everybody's looking at the pathology very carefully because the company doesn't want there to be any mistakes. We, of course, as investigators, want to make sure patients are getting the best care across the board, especially on a clinical trial, because there's that much scrutiny. So in some ways, the patient's getting the most catered to on a clinical trial. There's very little room for error. The pathology is often double-checked at a central pathology. Everything's done on a well-defined protocol and schedule, and it's made patient-friendly. So I often tell patients that, hey, if you take part in the clinical trial, you will be actually getting the highest standard of care of any patient that's getting treated for a particular disease. And you'll not only be helping yourself, but hopefully you'll be helping inform the field and help other patients as well. But we have to be practical. And I always tell patients, hey, clinical trial is a commitment. It's not as though you can skip appointments. It's not as though you can, not take part in every part of it. And if it's too much of a social or financial burden, let us know up front because there's no obligation. I never want patients to feel that if they say no to a clinical trial that I'm recommending, I'm going to take it personally. No, not at all. It's not a personal thing. It's me just trying to get them to take part in something that I think will help them. But if they can't participate, they're not going to hurt my feelings at all, and they still will get treated.
Well, again, Dr. Mott, thank you for spending the time today with us and also just everything you do for patients and care partners out there in this space. We really appreciate it.
It was my pleasure. Thank you so much.
All right. Now, I hope this conversation with Dr. Kamat helped you out there. Please feel free to share this discussion, the link, the info with others in your community. We want to once again thank our sponsors, Johnson & Johnson, for supporting this independent patient education program. We retain full editorial control. And while, again, we hope that this was really helpful, that you walk away with questions to ask your own healthcare team, this is not a substitute for medical advice. And finally, we want to hear from you. A survey is going to pop up in just a couple of minutes. Actually, it's going to pop up once this discussion closes. It'll only take a couple of minutes to fill out. And we really want to understand what you thought about this discussion and what we could do better, what you liked, and what you'd like to see more of. Don't forget to go to thepatientstory.com if you want an entire library of other patient stories. So that's it for today. So glad you could join us, and I hope to see you again soon. For now, I'm Stephanie Troll for The Patient Story. Take good care.